The anatomic similarities between the pulmonary and the liver circulations are the following. Both organs have two vascular inflow tracts. The lung has the pulmonary artery, which is the vasa publica, and the bronchial artery, which is the vasa privata, the vessels that supply the nutrition to the tracheobronchial tree. The liver has the portal vein, which is a vasa publica, and the hepatic arteries, which are the vasa privata. The hepatic arteries are the one that nourish the hepatocytes, and regeneration of hepatocytes and neoplasias can show increased hepatic arterial hypervascularity. The central arrangement of both inflow tracts is common to both the lungs and the liver. There is a lobar, segmental, and lobular distribution. The venous inflow tract has a large flow, low pressure system, which in the case of the lungs is the pulmonary artery, and in the liver, the portal vein. The arterial inflow tract is one that has a small flow, but at a high pressure. In the lungs, the bronchial arteries, in the liver, the hepatic arteries. Mixing of blood occurs from both inflow tracts at the capillary level, and this happens at the level of the pulmonary capillaries in the lung and at the level of the hepatic sinusoids in the liver. Capillary anastomosis and arterial supply to vasa vasorum of the portal vein and pulmonary arteries are potential intervascular communications. In other words, we can see the bronchial arteries connecting with the pulmonary arteries and the hepatic artery connecting with the portal vein in certain conditions. Other similarities are that surrounding systemic arteries are available when demand arises. In other words, ischemic lung conditions may receive blood supply from the chest wall arteries, the intercostals, the mammaries, and in the liver, the diaphragmatic arteries, particularly those that arise from the phrenic arteries, can supply the periphery of the liver. The lung and liver are vascular sponges, which act as a blood storage organ. We have a large amount of blood in the lungs as well as we have it in the liver. The origin of the hepatic artery and the bronchial artery can be normal, aberrant, or have accessory vessels. And finally, the hepatic artery and the bronchial artery supply more than their main organs, respectively the liver and the lung. The hepatic artery can supply the biliary tree, and the bronchial artery supplies mediastinal structures before it goes in. Functional similarities. The pulmonary arteries are responsible for the gas exchange mechanism. They are a blood reservoir for maintaining left ventricular output. They are the nutritive vessels for alveolar cells and alveolar ducts. They allow filtration of systemic venous blood. And finally, they provide absorption of alveolar fluid. The portal vein is responsible for the exchange of metabolites. Is a blood reservoir for general circulation. It is a structure that provides nutrition of hepatocytes. It also provides filtration of splanchnic blood, and finally is responsible for production of bile. Functional similarities. The bronchial arteries, which are best called bronchomediastinal arteries, provide the nutrition to mediastinal structures and the tracheobronchial tree. They supply the vasa vasorum of the pulmonary artery as well as of the aorta. They are the nutritive vessels to hyperplastic and neoplastic bronchial epithelium. And they are major compensatory vessels for absent or obstructed pulmonary arteries. For example, persistent truncus arteriosus type 4 and pulmonary thromboembolism. The hepatic arteries, or the so-called hepato-gastroduodenal pancreatico-biliary arteries, provide nutrition to stomach, duodenum, pancreas, biliary tract, and liver. They supply the vasa vasorum of the portal vein. They are the nutritive vessels to regenerative and neoplastic hepatic cells, and they are the major compensatory vessels for anatomically or functionally obstructed portal veins. For example, in patients with prehepatic portal vein thrombosis and the so-called category 4 of portal hypertension. Physiopathologic similarities. New growth and regenerative parenchyma are supplied by the arterial inflow tract of both the lungs and the liver. Decreased blood flow through venous inflow tract is followed by hypertrophied arterial inflow tract. That happens in the lung when there is occlusive disease, the bronchial arteries expand. When there is a decreased portal perfusion, the hepatic arteries expand. The compensated interruption of venous inflow tract may result in hemorrhagic infarction. Flow reversal in the venous inflow vessels may be observed in certain diseases. The lungs and the liver are capable of depending exclusively from their arterial inflow system. In conclusion, the pulmonary arteries are to the lung what the portal veins are to the liver. The bronchial arteries are to the lung what the hepatic arteries are to the liver. The venous inflow system of both organs play the dominant physiological role, and the arterial inflow tracts are the nutritive and compensatory system.